Hi, good evening. So today is the debriefing session for our EDIC 2 crash course. Where is Altaf has joined and another guy who was from Kenya. He has not joined yet, who has given the exam. Anyway, so let's start. So today I will discuss about domain 3. CCS, as you know that in your EDIC 2 exam, there is a two part. One is CCS and the CBS. CCS means case scenario based uh, discussion, and CBS means the computer based scenario. So, sorry, clinical case scenario and computer based scenario. So in CCS, you will get 4 cases, 2 long case, 2 short case. And the 2 long case, you will get more, at least 5 to 6 variant, and each variant there will be 4 to 5 questions. Sometime it may be 5 to 6 questions. And in short case, you will get maximum 3 variant. In a case, maximum 3 variant, and each variant is 5 questions. So last exam in the May, there was a case on pregnancy. There was a case on which I'm going to discuss. That is community acquired pneumonia followed by ARDS followed by ECMO, VV ECMO. There was a case of acute cardiogenic shock followed by your these things, the VA ECMO. So there was 2 ECMO scenario, and one case on pulmonary embolism, and another case was on, I think, traumatic brain injury. So this type of case was in the last exam in the May. So that's why I made all the case on basis of that. So just I want to know how many of you are appearing exam on 27th November. Susmita, do you have any idea among this student how many of them are appearing exam in 27th November?
Sir, I am appearing, sir. Hemraj Acharya.
Okay.
I am also appearing on 26, 27. So.
Okay. So my one request all of you that once you finish your exam, Susmita will communicate with you, and you, Susmita and me,
Yes,
obviously, the
sir.
online. So
Yes, sir.
just you give us the details about what cases given and what are the variant was there, I mean, the scenario was there for CCS. So it will help further your juniors, or when they will come to us, we can guide a better way. Uh, Here, all the cases I made prepare basis on the last exam. The scenario which you got in the variant is made up on basis of the previous scenario. So you might get similar case in your actual exam. So it is not important what question we are asking, but it is important what scenario we are giving. So question might be little change, but the flow will be the similar. So that here you will get some idea how you will get the question and how you will give the answer. Okay. So 18-year-old female, known case of type 1 diabetes on insulin therapy in, and she had a fever, respiratory distress, and admitted in the outside hospital where she was intubated. On viewing of worsening respiratory failure, yes, she has intubated and then referred to us. And when she was
So
with
can you
us,
full screen, sir? Can you
yeah,
full screen the slide, sir?
it
Like
is
slideshow.
not I'm doing the slide, so it is not coming on the slide. So
No, sir. We can see all the other slides also downstairs and next slide. So yeah, now it's okay. Fine. Thank you, sir.
okay. So new onset fever, and there is we have intubated this patient. Plateau pressure is 32 on 6 ml per kg tidal volume. Driving pressure is 16, and tracheal secretion, blood stain secretion is there. SpO2 is 94% on FiO2 0.7. Heart rate 120 per minute, BP 120 by 70, and random blood sugar is 280, and ABG showing that metabolic acidosis, hypoxia. The carbon dioxide is 32, lactate is a little high, 2.9, sodium is 145, and potassium is 3, and albumin is 3.5. You will get in your exam that all are milli equivalent uh, data. In India, we are doing the milligram per deciliter, but in European, you will get European exam, you will get their yes, milli equivalent. So here there will be a question, what is your working diagnosis? Okay. Then they will ask what is the other possibility. Okay. So it is a case of type 1 diabetes, community acquired pneumonia with severe type of community acquired pneumonia and need intubation ventilation, and probably she is going to ARDS kind of thing. So your first working diagnosis is a community acquired pneumonia, and because though this is referred from the other hospital, but this stay on the other hospital is only 1 day. That's why it is not HAP or VAP. So it is a community acquired pneumonia. And they might ask what is your differential diagnosis over here. And remember one thing, in EDIC exam, there is no negative marking. And also initially it was a 5-pointer, 4-pointer, 3-pointer answer. If you give appropriate answer, then you will get 5 point or 4 point or 3 point. Nowadays there is no 5-pointer, 3-pointer. Whatever the true is 1 point, whatever wrong is 0 point. So whatever you know the differential diagnosis may be positive, you just utter the thing. And another important thing in the EDIC part 2 exam is the time management. So in your in CCS, you will get time for each cases is around half an hour for your long cases, and short cases is around 15 to 20 minutes. So they will provide you the 4 cases before the exam. The first variant will be with you, and the second, third, fourth variant they will give you on the table. So first thing, when you will get the questionnaire is, the scenario. First, you read the scenario carefully, and you establish your diagnosis and your differential diagnosis. This is the first your role on the exam, and for that fourth scenario, you will get half an hour time to read and prepare yourself. Okay, the next question. So which patient want to ICU admission? Here might be asked the ICU admission criteria in a community acquired pneumonia patient. So, so what are the guidelines? You have to utter all these things and basis of which scoring system. So the carb 65 is very much what I can say. Carb 65 is very important, and the PSI score also important. And this is 2007 ATS, but 2016 ATS also come with a modification. So you utter all this score for the ISU criteria. That is about your ATS or IDSA criteria is if there is a one major criteria or three or more minor criteria, the patient can be admitted in the ICU. There is a other guideline also like Lung India guidelines having this criteria. But remember, you are giving European exam, so you have to utter only the European guideline, which is validated by European Society. So unless it is not, otherwise it is a wrong. Okay. So now coming to then they might ask, what is your initial approach? So whatever case you will get, first they will ask about some scoring or some scoring on the basis of prognosticate or criteria, and they might ask you about the investigation, what we will say. So initial approach for this patient. So stabilize ABC, and then after initial resuscitation, you have to follow the sepsis guideline. So you have to send the appropriate culture and whatever the investigation you want to send is routinely we do. And then early initiation of antibiotic risk factor regarding the MRSA or Pseudomonas or escape group of organism, they might ask, and they might ask you about the antibiotic. So here the your choice of antimicrobial, how you will select antimicrobial on basis of what guidelines or what is your protocol in the ICU. So it is still showing the GPC in cluster. So what might be the positive agent? So when you will choose antimicrobial agent based on possible etiology of pneumonia, and also as per the IDSA guideline about the community acquired pneumonia or in hospital acquired pneumonia, what you have to utter this guideline, and also you have to choose the antibiotic. So usually we choose in community acquired pneumonia is BLI with macrolide combination. And here because of there is a GPC in cluster, so you have to keep some MRSA cover also or MSSA cover. And also you have to talk about the PKPD principle if they ask, or you can utter these things. So
Sorry,
this is
Doctor, what
yes.
is the GB? What is the GBC in cluster B?
GPC cluster में what come is commonest is streptopneumonia in the GPC. GPC means gram positive class cocci.
Gram in cluster. Okay.
Okay. So this is the guidelines about community acquired pneumonia as per the IDSA. And you have to certain guideline you have to know in your before going to exam. One of the thing is that the IDSA guideline about your community acquired pneumonia, about your HAB, about your invasive fungal infection, about your MDSA or multi-drug resistant bacteria. So a bloodstream infection, you have to read from the IDSA guideline because they might ask you. Then common etiology for severe inpatient pneumonia. So you have to utter all these things. Major bacterial pathogen is commonest is Streptococcus pneumonias, but also you might get Mycoplasma, Haemophilus, Staphylococcus, Chlamydia, Legionella, and they might ask you about the what are the risk factor for pseudomonas infection. If there is any structural lung disease or chronic COPD patient, they might have a you might suspect pseudomonas aeruginosa, or patient on in hospital in house the home nebulization, regular home nebulization, they might have the emergence of MDR pathogen. They might ask you about the what are the risk factor for developing MDR pathogen in your patient. So investigation in severe pneumonia, what you do every day, you will utter all these things. Next, role of steroid. It is very important question for nowadays, because initially it was thought that there is no role of steroid in community acquired pneumonia, but new and new the evidence is coming and the guidelines has come on the role of steroid in community acquired pneumonia. So you have to know that name of the trial, the largest trial, and the outcome. So this is the guideline when there is a pneumonia due to influenza, fungi, or tuberculosis. Then there is you will not give the steroid. If the community acquired pneumonia in an immunocompromised patient, no, then yes, then corticosteroid not recommended. If the patient have cap with septic shock, yes, then corticosteroid recommended for septic shock. And if no, then patient with cap fulfilling any of the following severity criteria: inhalation of mechanical ventilation, and initial oxygen PF ratio is less than 300, patient wearing non-breathing mask, estimated PF, PO2, FiO2 less than 300, yes, then you can consider. And remember, for H1N1 or influenza, recommendation no, COVID yes, and severe pneumonia with ARDS, then there is a recommendation for the steroid. So you have to know all about the uses of steroid in community acquired pneumonia in ARDS also.
So it is related to other يعني cause with community acquired, not itself community acquired. يعني like septic shock, like
Yes.
ARDS, like patient
Yes.
asthmatic, concomitant with community acquired.
Asthmatic concomitant or COPD patient, you would usually give the steroid, but the thing is that you have to for your purpose of passing, you have to utter exact guideline. So this guideline, American Thoracic Society, this is this come in the updated one is come in the this 2024, and they have a diagnostic and treatment adult community acquired pneumonia has a the guideline what are the drug you will use, the steroid recommendation also, and the same American College of American Thoracic Society also publish a guideline for management of ARDS. So you read all these two paper. One is community acquired pneumonia related, and other is ARDS related. You will get all the recommendation where you can use the steroid, you can where you can use in ARDS, where you can use the recommendation about your what I say the muscle relaxant and all. Okay. Now coming to Vinian 2, after 72 hours of optimum antimicrobial therapy, which include vancomycin and peptide, and the patient develops septic shock, both ET and the blood culture positive for MRSA, vancomycin sensitive. Gram-positive cover escalated to linezolid in view of worsening hemodynamics and worsening PO2 FiO2 ratio 180 to 120, and plateau pressure is 34, DP is 18, tidal volume 400, PEEP is 8, NT-proBNP 700, USG chest. The findings, usually they might ask about the USG chest, the rationale of use USG chest here and what you are expecting. So when the patient after this peptide means BLBLI, piperacillin tazobactam, and the vancomycin still is worsening of the patient, and initial report was GPC. So you have to think about the MRSA coverage, which has good lung penetration. Now this is the this is the picture, the chest X-ray and your USG. So what is your diagnosis with this USG clipping?
There is a Tourette sign,
Sign
worsening of pneumonia.
and
No, worsening of the pneumonia, obviously, but I'm asking about the
pleural shred
Tourette
sign.
sign, sir.
Tourette sign.
Disruption of pleura, visceral pleura.
so it is basically
And
if it
static
is
air bronchogram.
yeah, if it is sorry, if it is if you see this type of picture, there is a prominent bronchovascular marking, and also there is a consolidation. So it is a collapse and consolidation both. So if there is a collapse and consolidation, you think about that there might be a mucus plugging or bleeding is there. So what are the possible cause of treatment failure in this particular cases?
Antibiotics, no, not as per the sensitivity, or if the
Very
patient
good.
is multi-drug resistant, or there is infection by atypical pathogens like mycoplasma and Legionella. So
Very
that
good.
needs to be cultured.
Yeah. So one is the your choice of antibiotic or dose not appropriate, or atypical pathogen nosocomial secondary infection, and infection complicated with like lung abscess, parapneumonic effusion, and non-infectious causes like cardiogenic pulmonary edema, PE, ILD, malignancy, all these. Now coming to your, in this case, when you will see that there is a collapse consolidation, so first thing you have to do a bronchoscopy, and we have done bronchoscopy in this patient, and we found that there is a clot in it, and this might causes the your collapse and consolidation. So after removing this collapse, the X-ray picture has improved. So they might ask about two questions. One is what is your, when you are choosing antibiotic for a particular infection like this case. So what are the factor you will see? What are the factor will influence about your antibiotic choice? Tell me.
So
What are the
risk factors for MDR infections like patient is dialysis dependent or any
no,
previous
no, no,
history
no,
of
no, no.
influenza.
Yeah, that's right. But we are discussing about the
Duration.
community acquired pneumonia. So in real exam, you will focus on your case on. Okay. So your case is going on
Also
the
diabetic.
community acquired pneumonia. So what are the factor which will remember when you will choose for antibiotic? So there are 5 factors. Anyone can utter for any particular antimicrobial agent. You should check 5 factors when you will use it. First of all, whether this drug is appropriate for you are thinking about the infection, like whether the coverage is okay or not. First thing. Second thing, the penetration and the site of infection. Whether your drug penetrate on the site, like there are a lot of antibiotic, not good penetration on the lungs. So when you are choosing antibiotic, you have to think about the site of infection and whether their penetration is good or not. Like TG cycline is a good antibiotic, but it doesn't work on the bloodstream infection. It is good for the soft tissue and the abdomen. Similarly,
Daptomycin.
yes. So the one is the site of infection. Second, whether the drug is penetrate or not. Whether this drug is adequately cover this your suspected organism or not. And third is the PKPD of the patient, the PKPD of the drugs, and the appropriate doses. Okay. So PKPD depend on the appropriate doses. Now coming to duration of antibiotic and the source control also important. You have to utter these things, source control. The duration of antibiotic, how long you will give antibiotic to this patient, IV antibiotic.
So we will see for the clinical improvement of the patient. So if the patient is febrile for more than 12 hours, if there is a decrease in the requirement of O2, and if the
Very good.
patient can
So
be
one is the clinical improvement, and second,
improvement in the chest X-ray, sir, imaging X-ray improvement, sir, decrease in the
that
requirement of
is the
oxygen.
clinical and radiological improvement, one criteria. Another,
Brocalcitonin.
yes.
Brocalcitonin and the drop of TLC.
Okay, so you are telling that culture clearance. So duration also you have a guideline duration. So you have to give minimum 7 to 10 days in a severe pneumonia, and sometime you have to give the 14 days depending upon the organism what you are getting. And second, the clinical response, how patient is improving from clinically and the radiologically. And second, is there any role of procalcitonin?
Yes, sir. Pro-rata trial has shown that the decreasing trend of PCT can be used for de-escalation of antibiotics.
Yes. So you have to do a serial procalcitonin and you have to check the trend. If the procalcitonin serially decrease and your patient clinically improve, you can de-escalate your antibiotic. So they might ask you here about the de-escalation, about the antibiotic stewardship. Okay. Now coming to the variant 3, after 3-day worsening of respiratory failure, deteriorate PO2 FiO2 ratio 80 started. Sorry, it is not NIV. It is mechanical ventilation and taking 600 tidal volume PS like that. And actually here little mistake. This is intubated, and you remember that patient intubated and the patient deteriorated further and PO2 FiO2 ratio has decreased. So what you going to do here on the same patient?
Sir, we will, sir, try the recruitment manuals for this patient, sir.
Yeah,
We will
this
start.
protocol.
So what are the possible problem in this treatment and clinic anyway? So this is the chest X-ray.
Yeah.
Okay. So it is further worsening.
Sir, perhaps the fluid overload has caused a lot of congestion in the lungs and
So here they might ask you about the what is your clinical diagnosis here. So one is the fluid overload, okay, and any other question?
VAP with
It-
ventilator associated pneumonia.
ARDS.
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 You are going
Pneumonia has
for
now
the ARDS.
progressed.
So
Yeah.
you have to be a little smart also. So you have to understand that what will be your direction. The examiner kahan pe le jas, where they are going towards. So the patient admitted with the cap, then further deteriorated means the patient going to develop ARDS, and so they might ask about the ARDS management. Okay. So all you have to think about the what are the possibility. One is the patient might develop failure, that will be your DD. And if the examiner not if the examiner what other possibility they might ask, then you have to think about the ARDS. Now in ARDS, they might ask about the ventilator ventilator strategy. So ventilator strategy क्या होगा? What will be your ventilator strategy in ARDS?
Low tidal volume of 6 ml per kg and high PEEP, sir, according to the ARDSNet protocol.
So the thing is, that means open lung ventilation. So here you have to know all the trial, which supported the open lung ventilation, low tidal volume, high PEEP, and ARDS, if PEEP and FiO2 network, and Armatal also. So these are the thing you have to utter. So here it will be your low tidal, targeted PEEP less than 30, targeted pH permissible hypercapnia, driving force 14 to 18, and they might ask about the mechanical power, because now all trial going on the mechanical power. So what is the difference between your driving pressure versus mechanical power, and interpulmonary pressure monitoring has any role or not. So this is the CT of this patient. So can you describe the CT?
Sir, there is
bilateral
bilateral
pleural effusion.
This is not effusion, it's a dense consolidation.
Bilateral granular glass opacities, and
so it is a full-blown ARDS like picture. There's a basal consolidation and GGO all over the lungs. So PaO2, FiO2 persistently low. So recruitment maneuver, what recruitment maneuver you will do, and what is the evidence said about the recruitment maneuver?
So ProSeva trial has shown benefits in proning the patient, prone positioning of the patient.
Yeah, so recruitment only, the proning is a recruitment is accepted. No other recruitment maneuver, which is initially in our training phase we used to do this recruitment maneuver, has no role. Now coming to the proning ventilation. Proning ventilation, ProSeva trial shows is a positive response. So how much how many proning you will do, and what will be your duration, and how will you understand that proning is working?
Sir, if the patient's PF ratios are improving, sir, and
yes,
if we can come down on the PEEP while after proning, if the PF ratios are improving, and even after decreasing the PEEP, sir, the PF ratios are not dropping, that means the recruitment is getting better. The VQ mismatch and is better now, sir. The aeration of the posterior basal lungs are getting better, sir.
So what is the first you tell me how many proning you will do.
Sir, we can do as many as proning we want, but we can limit around 5 to 7 proning, sir, of around 16 to 18 hours a day.
So when you will say it is a proning failure?
If persistent, sir, PF ratios are poor and we are facing a hypercapnia, sir.
Okay. Yes. So if the that's there, so after 5 proning, if there is a no recruitment happen
Benefit.
and no FiO2 requirement reduce or lung compliance improve, that means your proning failure. So how physiologically proning? Acha, we will come about the proning. So role of APRV.
APRV is a mode where the patient can breathe on controlled ventilation and spontaneously, simultaneously. Basically, this helps in increasing the mean airway pressure of the patient. So it is again a kind of recruitment only where it helps in opening up the collapsed alveoli.
Okay. So what is the evidence suggest about APRV?
Sir, no mortality
Low
benefit.
mortality benefit,
Improve the
only
oxygenation, but
improves the
without
oxygenation.
Any trial name on the APRV?
Oscillation trial. No, that was a HF.
Oscillation trial.
It was HF
HFL, no,
only.
that is
Yes.
HFL.
So role of inhaled nitric oxide?
improve the oxygenation, but not the mortality.
Yeah. And they might ask about the HO,
High frequency oscillation.
high frequency oscillation ventilation. This is banned. Yeah.
Increase the mortality.
Yeah. And how will you optimize non-ventilatory management of ARDS?
Sir, keeping the patient sedated and with relaxed light accuracy trial has shown mortality benefit with say cetracurium.
Yeah. So, but again, you can go through your American thoracic guideline for the ARDS, updated ARDS management that is published in 2024. And one is your fluid management. You have to utter on this fluid management. It should be a restricted fluid management. Second, the role of your attracurium, the muscle relaxant. First 3 or 5, 3 to 5 days, there is a good mortality benefit. But if you do prolong, then the recommendation is no, because it causes the it produces critical illness neuropathy. Again, the steroid also the same. The initial stage has a role, but you can't go prolong. Then you have the physiotherapy, passive physiotherapy. You have to start from very beginning to reduce your critical illness neuropathy. And second, about the nutrition. They might ask about on the nutrition question that there are few supplement role of omega-3 and all. So you have to know that the full about the nutritional management in a ARDS patient. Okay, that's why this is called non-ventilatory management of ARDS. And any modification on the ARDS definition?
Other than Berlin, sir.
In Berlin. In Berlin.
In non-ventilated, non-intubated patient, we can consider ARDS on high flow nasal cannula or non-invasive ventilation.
No, actually, they have sorry. You can go through the article. I will send you the article that new guideline says that PO2, we diagnose what are the things: time, onset, it should be acute,
origin,
onset, non-cardiogenic, and PO2 FiO2 ratio should
bilateral.
be
Bilateral opacity is not due to the collapse nodules.
Everything is there. Only the PO2 FiO2 instead of PO2 FiO2 ratio,
Saturation by
they keep saturation and FiO2. I mean FiO2 and the saturation ratio. Why they included that saturation in FiO2 ratio? They have seen that it is more or less similar with PO2, FiO2, and like third world country in India or Bangladesh or Nepal, Sri Lanka, Asian country, in all center there is no ABG facilities. So if you have no ABG facilities, you will not say that this is a ARDS case. That's why SpO2 is easily available everywhere. That's why they included the SpO2 on the criteria on the diagnosis. Okay. So the prone position, procevertile, and mean duration at least 70 hours and 4 session average. If you there is a improvement in the your lung compliance is okay. And how the physiologically prone position is recruiting your lungs. Tell me.
Causes homogenization of the ventilation, and also blood flow goes from the dorsal to the ventral areas. So perfusion is also better. And
Decreases.
the mediastinal weight, the weight of mediastinum, the effect of compression of
So
mediastinum.
three factors. One factor is a the homogeneous ventilatory flow distribution, and second is your when there is a supine, the maximum area of your the well ventilated and perfusionist area is the zone 2. So basically, we are increasing the zone 2 by doing prone. So you know the Wells zone of zone 1, zone 2, and zone 3. Zone 1 means where the ventilation is higher than your arterial pressure, than your venous pressure. And zone 2 is the arterial pressure is
is
higher
more
than the
than
ventilator pressure, then the venous pressure. And zone 3 is the arterial, venous, and the ventilatory. So in the zone 3 is most of the time due to there is a over perfusion but less ventilation causing VQ mismatch. And in the upper area, the zone 1 where the alveolus is over distended and low perfusion, therefore there is a VQ mismatch, and the maximum ventilation and perfusion happen in the middle zone, zone 2. So that is in the normal situation. And when there is a ARDS, again there is a three parts of the lung, the baby lung. Why the baby lung concept come? The lower portion is consolidated portion. Whatever pressure of air you give there, the alveolus will not open. And the middle zone, what is the recruitable portion? Where if you increase the PEEP, there is a chance of open up and increase the surface area of the ventilation. And again, the upper lung, which is a normal portion, if you give more PEEP or more tidal volume, it causes the over distension and it causes the zone 1 effect. So when you are doing the prone ventilation, so the secretion on the alveolus, it is a sticky secretion. The secretion will move from the alveolus to the bronchus, and it increases your middle part, the surface area of the lung, and the reduce your ventilation perfusion mismatch. And also obvious, you are right that the weight of your heart is also compressed little bit on the lung surface. So when you make proning position, this weight is not effect on the lungs, therefore it increases your lung ventilated area. So it also help reduce the VQ mismatch. That's there. And effect of inhaled ventilator on the blood flow. That's I have already mentioned. So this is criteria apply in the ARDS definition, that is PO2, SPO2, FiO2, SPO2 criteria. That also you will get in this American College of Thoracic Journal or Thoracic Society Journal. And now coming to the Venian 5 here, we have made this case CP ventilated 5-cycle phone ventilation patient develop cardiac arrest, but in a actual which given in the May cases, they ask you have a failure on the prone ventilation. So what you will do after 5 cycles? There is not improving. So what will be your next strategy?
Sir, we will counsel the patient's relative about ECMO, sir. Will be ECMO.
ECMO, yes. Now you tell me the indication of ECMO.
Sir.
ECMO is very hot topic in the exam after the COVID. Every exam they have given of the ECMO scenario. So tell me about what ECMO, what is the indication? Yes, indication and the classification of the ECMO and which modality you will use here. So first is indication.
PF ratio less than 80 for 6 hours after trying all the measures.
Yes.
When mortality is more than 80% without
That mortality is come late. So one is the PF ratio and another criteria persistent. Yes, Murray's criteria or score. So tell me about the point.
sir, there are 4 criteria. PF ratio, lung involvement, lobar involvement, how many quadrants, compliance, and how much P patient needs.
And
so if these 4 criteria are there. If it is more than 3,
no, one criteria, one persistent acidosis. Persistent acidosis, pH is less than 7.15 and the CO2 is more than 80. Persistent acidosis you have to utter.
Okay.
So just you check on the Morris criteria. Okay. So now it is an indication. ये हो गया कि तुम्हारा prone failure हो रहा है, ARDS माने your patient having prone failure, ARDS is going on, PO2 ratio persistent low. So you are thinking about the ECMO. So what ECMO, what modality you will give? So classification of the ECMO.
Veno-venous ECMO, veno-arterial ECMO.
Veno-venous, veno-arterial. Any other?
VAV.
VAV. Veno-arterio-veno. Okay. So here, which modality you will use?
Veno-venous, hoping that her heart is still open.
Veno-venous, you will. So they might ask you about the cannulation site and cannulation technique. So cannulation site for the veno-venous?
Femoro-femoral or femoro-atrial?
Femoro?
Femoro-femoral or femoro-atrial?
No. That is veno-arterial you are talking. I'm asking about the veno-venous, where we will put your cannula.
Venous cannula in femoral vein and right IJV.
So either femoro-femoral, so both femoral vein or femoral to IJV. So femoral will be your drainage cannula and return cannula on the right IJV. Okay. So what will be the gap between two cannula? The tip
at least 9 to 10 centimeter gap.
Why?
Recirculation.
To avoid recirculation.
Recirculation. How will you understand that recirculation is happening?
If
The tube
the arterial and
right?
venous cannula both look bright, like या फिर in oxygenator, if pre-oxygenator saturation is
High.
good or SVO2 is very high,
So here two things will happen. One is the color changes. Second is your two limb, the drainage and the return and the drainage cannula, the pH you have to check. Sorry, PaO2 you have to check, and also you have to check the SpO2. Okay, so if the patient desaturate in the ECMO and there is a no changes in the color or the drainage limb and the return limb has no difference or very less difference, then you can think about your uh,
oxygenation failure.
মানে not oxygenation failure, your recirculation is happening. Okay. Acha, you tell me about the causes of low pressure on peripheral V. Acha, we are asking about the VV ECMO, na? And now you tell me that if there is a alarm given in the your ECMO, so what are the troubleshooting you will do? क्या क्या देखोगे? माने what will the things you will see?
Access pressure, cannula pressure, it how negative it is. Then
Okay.
pre-oxygenator and post-oxygenator pressure and pressure drop.
Okay. So pre and post oxygenator pressure drop will give you the membrane pressure of the oxygenator, whether there is a clot or not. Okay. And one thing is that when there is a alarm is given, so first you have to check the whether the circuit is having shattering or not. If the shattering is there, then means there is a flow starvation is going on. So either patient may be hypovolemic or the cannula position, cannula kinking is there. Okay. Second, you will check the RAM. Your RAM is okay or not. Your whatever you have set the cardiac output, that is maintaining or not. These things, and then you have to check the your pre and post pressure, and also you have to check the ACT. So what will be your targeted ACT?
So around 160 to 180 seconds.
Usually is 160 to 200. Okay. And if your patient is coagulopathic, then what will you do?
So we can keep flows high,
Yes,
blood.
very good. So you have to keep the flow high when you are not able to give the heparin or any form of anticoagulant. So for 10 points, you have to remember for the ECMO, selection of ECMO mode, size and site of the cannula, and you have to do echo pre and post ECMO to establish and seriously flow and volume status and cardiac function, and also proper anticoagulant. So what anticoagulant you will use?
Unfractionated heparin, and
First choice is the unfractionated heparin if there is no contraindication. Okay. And then you have to check the pressure. You have to observe the pressure of your P and post, and establishment of the flow and whether flow is maintaining or not. and you have to check the pulse pressure. Because there will be a linear flow, so you will not have the arterial cannulation like your normal arterial cannulation, the pulse pressure we found. So that's why the important is the mean arterial pressure monitoring, and also you will check the urine output, and very important, the distal perfusion of the cannula, especially because it is a wide bore cannula. So when you will use in the femoral vein or femoral artery in a VA ECMO, is routinely you have to give the distal perfusion cannulation, and in femoral or femorojugular, yeah, femoral venous drainage you have to check. Okay, these are the troubleshooting for your VV ECMO. And you tell me, if the patient having the renal failure, how will you do the CRRT or SLATE to this patient?
Sir, at 3 different places we can
Yes.
connect. So the post membrane, we can take the blood out and again give after pump before the oxygenator.
Yes, remember, you have to take the blood from the drainage cannula, and you have to drain the purified blood in the drainage cannula, not post
Yes.
oxygenator. Okay, that is very important. You have to remember. So it all should be in the drainage cannula or before the your oxygenator. You will not put anything on the after the oxygenator unless antibiotic and all.
So
Okay.
we'll increase venous cannula, يعني we'll add on another venous before oxygenator or what?
Not need there. There will be a connector, or you can introduce a connector. In the those who have worked in the ECMO unit, you know the cannula. In the drainage cannula, there is a connection for the CRRT. Okay.
So we'll take connection from the drainage and then return where?
Yes, drainage cannula itself. From the drainage cannula, one principle you remember, whatever you are collecting blood and your purification and done, everything should be done in the pre-oxygenator to reduce the any clot related complication. Okay.
Okay.
So you say, what is ST 162nd? What is that?
Yes.
What is ST? I'm sorry, I didn't get.
What
ST, you are telling keep ST 160 to 200. What is ST?
ACT, activated clotting time.
Oh, okay,
ACT
okay.
is the
ACT.
activated clotting time. Yes.
Okay.
So either you can do APTT, you should keep APTT more than 3 times, or bedside ACT, activated clotting time, it is 160 to 200. Okay. Now coming to your CBS, 2-3 area in the CCS you should prepare yourself before going exam. One is the ECMO, I said. Second is the brain death patient for organ harvestation. So criteria for brain death, how will you keep organ perfused before the organ harvestation, and the criteria for the organ harvestation. ये सब तो guidelines पूछेगा, it will ask. And second important thing is that nowadays it is they are asking about the patient who develop critical illness neuropathy like this, or patient maintaining on the tracheostomy, the home the home care therapy about how will you advise your patient for home care, family counseling. These are the things they are asking. Okay. Now coming to CVS. So what is this problem? And outline treatment.
So in large right gangliocapsular bleed with intraventricular extension.
Yeah. So
With
treatment.
the surrounding edema. Raised ICT signs, immediately we need to put EVD and then take patient for OT.
Okay.
Anti-edema measures before that.
Yeah. So sorry. So first thing is that you in CBS again I'm telling there will be three table, one table for the image, one table for the curve and loop, and one table for your the investigation report, the case scenario with blood investigation where they can give the blood report, they can give the ABG, they can give the your CSF study report or pleural or ascitic fluid. So here again, the main aims is time management. In each variant, there will be a 12 to 15 question. Okay, each table. You have to answer 10 question. So you might have the 2-3 question you are not exactly understanding. So don't waste your time. You skip the question, and if you have a time, so you will get 10 minutes or 12 minutes. 12 minutes. I exactly forget. So by that time, if you are not able to understand what is in the step, then you skip the question and remember the number of these things, and you ask. You have a if you have a time, come to this question, and you will again rethink and give answer. That's one thing. And here the OSCE table, they ask about your diagnosis and the management. So management not elaborating. So management, like here, it is a IVH and ICH. So the management is you have to reduce the intracranial pressure, you have to drain and putting the EVD in this thing. So the management only outline, not in the details. So coming to the next question, 40-year-old male, morbid obesity, BMI 40, chronic smoker, hypertensive, admitted with fever, chest pain, and it's a dyspnea on exertion. So last 3 days treatment with severe cap, intubated, ventilated. She was worsening from the ventilation, getting ambulated when he developed new onset hemodynamic change, heart rate 140, BP 100/50, SpO2 95%, FiO2 100. Urgent CT scan you have done, and this is the CT. So, what is your diagnosis here?
Bilateral pulmonary embolism
Yes.
with pulmonary trunk is larger than the ascending aortic diameter, dilated pulmonary trunk.
Yes. So, Sardar, tell me
RA.
about the plan of management.
So he is hemodynamically unstable.
Yes.
The we need thrombolysis in this patient if no any other contraindications.
So, what is the agent you will use for thrombolysis?
We'll prefer altiplase because that is the FDA approved agent. So 100 mg over 2 hours we can give.
Tenecteplase we will use.
Tenecteplase also, but
Yeah.
And the dose will be like in a weight of 70, we can use 35 milligram. In a weight
Yeah.
of
What is
100, we
the
can use maximum dose, we can use as 50 milligram.
What is the contraindication for
Sir,
thrombolysis?
any intracranial hemorrhage in the past, sir? Any stroke in the neuroaxial surgery done in the last 3 months? If the patient's INR is more than 1.6, platelets are less than 50,000. Any brain tumor, sir? Any aortic dissection, any aortic aneurysm?
Yeah, good. So in pulmonary embolism, you have to know the guideline of thrombolysis and your contraindication and method. Okay. So coming to this third question, 30-year-old alcoholic admitted with acute abdominal pain, intermittent fever, repeated episode of vomiting in last 3 days. Oh, why this? He was started empirical antibiotic, IV fluid, and intermediate opioid for pain relief. Now on fifth day of illness, PCT abdomen was done. What is your diagnosis?
So this is
Sir, diffuse.
edematous pancreatitis.
And outline the treatment. Strep pancreatitis or something else. Collection on the fluid is there, no?
Yes, sir. Aside peripancreatic collection.
So it is it pseudocyst?
So it's
Unlikely.
the fifth day of last
This is
three
wall
onset
of
is
necrosis.
Hmm?
onset
Wall
is
of necrosis.
days only, but walled off cannot happen in 3 days.
Okay.
Very unlikely, sir. On day 5th, is the pseudocyst
So
formation.
it's a peripancreatic collection.
Yes.
So what are the ICU scoring system to for the prognosticate on the pancreas?
So
Your
The Ranson's
Bishop is
criteria, bicep score,
yes,
Apache score, sir.
Apache 2, yeah.
and CT scan scoring.
CT, sir.
Balthazar and
Yes.
Atlanta score.
So you have to know all this code in details. Okay, they might ask about the in details of this coding. So what is the problem over here?
J waves, it's
Yes.
hypothermia.
Usually they will give the stem about the scenario, and from this stem or from this scenario, you will get more than 80% cases answer. Like if they give you this type of picture, they will give you scenario about hypothermia. Okay. So they will ask, and what is the management of it? Now coming to these things, 40-year-old male CKD, bi-weekly dialysis, admitted fever, chest pain, SOP for last 3 weeks, and on examination, diaphoretic, anoxas, respiratory 40, BP low, chest examination, normal vesicular breath sound, heart sound difficult to auscultate, 12-lead ECG,
Cardiac tamponade, sir.
electrical alterance.
So
Yes.
this is the chest X-ray, and so it is a cardiac tamponade.
Yeah.
And how do
لا
you
not
perform?
the right ventricle not collapse. We need moving picture video.
Treatment choice?
Pericardiocentesis.
Paracentesis.
Pericardiocentesis.
Sir, this case has a history of fever, shortness of breath. So, should we mention pericarditis or constrictive pericarditis? Should we mention?
Constrictive pericarditis. Now you are
Fluid.
seeing that fluid is there.
Okay.
So pericardial effusion is there. But whether you will say the tamponade or not, because look here, the BP is low. So there might be chance of tamponade. Okay. Though there is other picture is not given, the CVP or the things. But patient is in shock because it's diaphoretic, anoxia, respiratory rate high, blood pressure is 90/50. So you can say, but you
Muffled heart sounds.
in the
Low was.
component you will see the right heart is collapsed, but here the right heart is not collapsing. I mean, not collapse on the so D-shaped right heart over distant. Usually in the that is on the
Pulmonary embolism.
pulmonary embolism. Here in the right ventricle little bit collapse because right ventricular muscle mass is very less, so it become collapse in the tamponade.
Yes.
Anyway, what is happening here? Just anyone read out and tell me the
30 year-old multi-gravida delivered full-term via general anesthesia in view of preeclampsia. Heart rate 120, BP 180/110. In view of PPH, she was transfused 4 FFP4 platelets. Post LSCS, her oxygenation deteriorated and was shifted to ICU. Echo reflects LA pressures of 14. Started on labetalol and IV magnesium infusion therapy. Possible differentials, etiologenesis and treatment. So it could be fluid overload, TRALI.
Yeah.
Pulmonary edema because of cardiac.
Associated circulatory overload.
Yeah, TACO could be there.
So the mainly two differential, either it is a fluid overload or TRALI because got transfused 4 FFP4 platelet. So what is the commonest blood product which cause TRALI?
Platelets.
Platelets or FFP?
FFP, sir.
FFP is called TRALI.
Yes, sir.
Peripartum cardiomyopathy also.
Yes. Now tell me the problem.
Ineffective.
Effective
Ineffective.
Trigger.
So here is a trigger asynchrony. So ineffective trigger. Okay, how will you manage? And why it is happening?
Sir, maybe the sensitivity set is very high, sir.
Auto beep.
COPD patient, so auto PEEP might be the reason.
Very good. So one is the the correct answer is the auto PEEP might be the cause because this COPD patient, and second is the you have to check the setting also.
Yes.
What is the trigger you have said? What is your diagnosis?
Brain dead.
Yes, CT scan. If you see this type of CT, no need to read about the stem. So they might ask you about the criteria of brain death declaration, and they might ask you about the apnea test. Okay. So what will be your, how will you perform apnea test, and what will be your first apnea to second apnea duration, and the criteria who will be present during the apnea test, who will do the apnea test. Okay. So read about the apnea test because you might get question from the scenario or from the CVS about organ donation. Now it's a big stem. This question, 40. Anyone can read.
43-year-old woman with medical history of type 2 diabetes and morbid obesity presented to the emergency department with problems of generalized weakness, nausea, vomiting, cough, shortness of breath for 1 day. She is on metformin 1 gram twice daily. Over the last 3 years, empagliflozin 25 mg daily was started 2 months earlier. The patient reported that she had been on ketogenic diet for the last 2 weeks and denied having similar episodes in the past. Tachycardic heart rate of 130, tachypneic respiratory rate of 24, blood pressure 115/80. Temperature 37.2, body weight 88 with BMI of 31. On physical examination, she was moderately distressed, mucous membranes and skin appears dry, abdomen non-tender distended, lungs were clear to auscultation bilaterally. Neurologically, she was awake, alert, oriented to self, date, place, no focal deficits. Rest of the examination was within normal limits. Laboratory testing, leukocytosis 20.4, lactic acid is normal 1.8. Electrolytes, potassium is 2.9, sodium 141, chloride 115, phosphorus 1.3, bicarbonate 5, glucose 169, blood urea nitrogen is 24, creatinine 1.6, albumin 4.2, beta hydroxybutyrates more than 60, lipase 194, ABG pH is 7.01, 7.01, PO2 119, CO2 of 5. The patient urine was positive for ketone, body is more than 80. Urine drug screen was negative, osmolality was 304 with calculated osmolar gap of 8. Glycolated hemoglobin is 10.2, anion gap is 20.5. Urine acid was positive for ketones, glucose and protein. Nitrates and leukocyte esters were negative. ECG shows sanitary. Clinical diagnosis going with severe decay. Outline the approach of the treatment, ABC stabilization, transfer to the ICU, fluid resuscitation, correction of the electrolytes. Because potassium is 2.9 before I administer insulin, I will go with 0.1 units per kg per hour and involve endocrinology team. And I will aim for reduction of ketones 3 millimoles per hour, glucose.
How will you monitor response of the treatment?
I would do serial ABG looking for a correction of anion gap, closure of anion gap, and reduction of the glucose.
Though I have kept this stem over here, but you will not get the long stem like I have given here, but you might get the decay question on the CBS. But remember, they will ask about your clinical diagnosis and the approach of treatment, and they will purposefully give you the potassium low. And if you not utter that potassium correction you will do before starting the insulin, you will not get marks over there. Okay. So that's there. So the last question, identify the problem and possible measure.
Sir, in the last question, the diagnosis could be starvation ketosis also, sir. Sugars were normal and she was obese and she was trying to lose weight, sir. And maybe the hypokalemia could be due to the bulimia nervosa. She is continuously vomiting out, sir. The sugars are normal right now, sir. Diabetic ketoacid or ketones are positive acidosis, but diabetes is not there, sir. Sugars are 169 only.
Because of empagliflozin, she can get low euglycemic.
Yeah, so euglycemia is there.
The whole picture is going consistent with uncontrolled diabetes. Beta hydroxybutyrates are high. Severe acidosis.
Starvation ketosis will also have high beta hydroxybutyric.
Not this much, actually. These are very.
I don't think so. This much will be caused by
starvation. And look at the osmolarity. Starvation ketoacidosis osmolarity will be high like that. Osmolar gap.
Can be also mala. There's another cause of acidosis, also lactic acidosis, because of metformin.
Lactic acid is normal here.
It's you can debate on the starvation ketoacidosis.
Osmolar gap is normal only 8 milliosmoles, sir. Less than 10 is normal. It's not high.
So the house, tell me, how many of you fought on the starvation?
Sir, sugars are 169. You will start insulin. Sugar will further fall, sir. She is already on ketogenic diet.
Actually, the stem gives the patient is on empagliflozin. So this patient is having most likely euglycemic decay.
Euglycemic ketoacid, yeah.
So euglycemic diabetic ketoacidosis.
Maybe. So I will come to you with this details, okay? And next question.
Auto peep, sir.
Auto peep to likha written. But another problem is there. Why this auto peep is happening?
Flow starvation is also there.
Yes. So there is a flow starvation, and
it is maybe it's early cycling That's why patients' demands are not met.
Yes.
Inadequate IE ratio, sir. Expiratory
Yeah.
phase is shorter.
Yes.
IE is 1:1.1.
Yeah. So that's why, because of inadequate your I ratio and the flow starvation, there is a autopivy is happening. So what is the measurement?
So increase the expiratory phase, decrease the tidal volume, and we can decrease the RR also.
Yes.
Or we can change to flow variable mode also.
Patient looks like ARDS
specific
and
flow.
we can يعني disconnect patient, paralyze the patient.
So you are talking about the auto PIP management, but here you have to understand the why is auto PIP happening, because of your this is the I ratio is not appropriate, and there is a flow starvation, and you are given the high respiratory rate, which is might be this patient is COPD patient is not able to remove the carbon dioxide. So you have to take a correct measurement on the respiratory rate, on the flow, and if you increase the flow, automatically your I ratio will improve.
So we will set, sir, if it is a hyperdynamic inflation, we set the PEEP of 80% of the auto PEEP. We will calculate the auto PEEP and we will set the PEEP to it. In this, we can see the PEEP is set to 14, which is too high, sir, already.
Yes. So this type of question you will get, okay, in your real exam. So the basics of giving you taking this crash course, the motto is to make you understand what type of question you might get and what is the flow of the exam. Because most of you are the first time you are giving the exam in the crash course. So in EDIC part 2 is basically the exam is about the time management and your practical ideas, because they check your knowledge in the part 1, the depth of knowledge they check in the part 1. And tricks of this exam is you have to know the guidelines and you have to know the protocol, and they will judge you whether you are able to manage patient as a register, because once you pass the EDIC 2, you will get the EDIC pass certificate, and once you will have this EDIC pass certificate, you are eligible to apply for the GMC registration and also apply for the job in UK, and you will be they will give you job as a register, okay, register or locum consultant. So they in this exam they want to know whether you are safe for the patient or not. So be humble, follow the guidelines and protocols, and remember what you are doing day to day in your life in ICU. You just utter all these things, and time management is a very big factor in this exam. And what I have suggested, the all the cases like that, I have made all the scenario, the exam, the all our faculty, they made the stem and variant. But the flow which I have found in the last exam, according to I have done these things. And for what are the book you are following for this exam, the part 2? Any particular book you are following?
OSCE for intensive care medicine.
That's good. And one is the data interpretation book. You can go through.
Examination intensive care medicine.
Yeah, that's good. Okay. So best of luck, all of you.
Ammal Matu.
Anyway, best of luck, all of you.